may find them having a syncopal episode. On your EKG and, oh, look at that, they're a block. Okay? All right, so sometimes the impulses get delayed. Usually due to some sort of damage in the heart, in the electrical system, from ischemia or damage in the cardiac tissue. Right? So, our first degree blocks is defined as PR interval greater than what? 0.12 seconds, right? So, or 0.20, I'm sorry. So, greater than 5 little boxes is a first degree block. Is it generally dangerous? No. It might be a finding that we find they may or may not know they have it. It's generally not the cause of them calling 911. Okay? So you can mention it to the hospital, but it's like not a big deal. Okay? So we're not treating it because it usually doesn't need to be treated. All right? So anything greater than 0.20 seconds for a PR interval. Now we have our Winky block, or Mobitz 1, or second degree type 1. It is called all 3 of those things. It is the same thing, but it has 3 different names. Why? Because some doctor named it. 2 doctors named it, Mobitz and Winky block. Okay? They like to name things when they discover it. All right? So just be aware that it has 3 different names, but it is the same rhythm. Okay? So what happens is you get your PR intervals that get longer and longer until it drops. So you end up having more P waves than you do QRSs, okay? But it's irregular. But the thing you have to remember is that the PR interval gets longer and longer and longer, and then it drops the QRS. Okay? You're not going to see it a lot, but occasionally you do. Have you seen one in the field?
A first degree or a second degree?
Second degree type 1.
I don't think so.
I've only seen it like 3 times in 30 years. So you don't see it a lot. And the last guy I had with it last year, he had a syncopal episode. And I put him on the monitor, and I was so excited, like, he's got a Winky block. He thought I was insane. But hey, I thought it was exciting. So, all right. If they're stable, they've got a good blood pressure, they're mentating well, their skin's good, we're not going to treat this. Right? If they're profoundly bradycardic and symptomatic, then we will treat it. How would we treat it? Hit some bumps on the way to the hospital? What?
Bueller.
Somebody yell something out. Atropine. Fluid. Pacing's possible.
Cars.
Oh, you're wanting to kill him.
I'm surprised you didn't say Craig.
Let's try not to.
Why would you not give cortisone? What does it do? Slows things down, right? So this is already probably kind of slow, so you don't want to make it slower. So we want to speed it up if they're symptomatic. Okay. So atropine, fluid, possibly pacing. Now, can this go from a type 1 to a type 2 and even a type 3 and go back and forth? Sure. People don't follow the rules and do what they want, and they can have more than one thing wrong with them if they want to as well. So, you have to evaluate the whole patient and what's going on. So they can go in and out of different rhythms. So they may require pacing. If it's just a straight on second degree type 1, probably not. But you gotta keep your eye out and see what happens. And if they do funky things, make sure you print that out to give it to the hospital. They do eventually get our PCRs, but as to if it marries up with the patient chart at a convenient interval for the cardiologist to actually see it, I don't know. So if you can print that and give it to them, it's helpful if they're having some kind of dysrhythmia. Right? And sometimes you may be the only people that capture it. Like for SVT and stuff, there's many people that will get, and they're like, yeah, they couldn't capture it, they put me on, you know, the home monitoring and all that stuff.
Yep, exactly.
But we captured it, so you gotta print it and give it to them, so they have proof when they go to the cardiologist that, look, this actually happened to me. Right, or the lead just fell off. I can't believe they said that. That's crazy. Do you know which doctor that was?
It was
Resident?
no, she actually runs the pediatrics of Garnett.
Well, that's scary.
Interesting.
And she was the family's friend, because his mom was a nurse and dad is a doctor.
I wonder if they're still friends. After that. I mean, that patient could have died.
Oh, yeah.
That's crazy.
She did just for a little bit.
Hmm?
She did just for a little bit.
Yeah, well, but,
17 seconds.
yeah.
And woke up with nothing happened.
Yep. All right. So, what can cause a Winky-Bach? Ischemic heart disease, an acute inferior wall MI, or that has right ventricular involvement. Okay. So, what does your right ventricle depend on to work well? What does it need?
The right ventricle?
Preload. Okay? It needs that blood and that fluid to come in order for it to push it back out. Okay? If you don't have blood return to the heart, things are not going to go well. Right? So that's why we have to be very careful with nitroglycerin with somebody having an inferior wall MI that has right ventricular involvement, because if you dilate everything, are they going to have good preload and good return? No. And guess what's going to happen to their blood pressure? It's going to tank. And then you're going to go flat, right? So, if you have somebody that has an inferior wall MI, so you'll learn more about where this is, but it's leads 2, 3, and AVF on your 12 lead, okay? You have to suspect there might be right ventricular involvement. Does anybody have any idea how we would figure that out? Do you know, Rob? Annie?
Huh?
Huh? How would we figure out if somebody has right ventricular involvement?
Ask you.
No. All right, you do a right-sided, you move your chest leads over to the right side and see if there is elevation, okay? And that will tell you if there's right ventricular involvement, okay? So,
Elevation in the ST still, or?
Mhm. Yep. So you'll see it in 2, 3, and AVF in terms of your regular 12 lead. But if you want to see if the right side's involved, then you can move it over to the right side and see if you get elevations on the right side. Okay? And you have to write that on your EKG so that they know that's the right side of the EKG.
The whole 12 lead or just the...
But it's in the chest leads. You'll see it. Like, so B1 through 6. Okay. So, you don't want to give that patient nitroglycerin. You do want to hang a 1,000 bag because they are more likely to be hypotensive. Okay, and they need that preload. Okay. You can give them pain meds. You just have to be judicious with it. Okay, so you can give them fentanyl, but maybe start out with 50 micrograms and have your fluids ready. Okay, they're always going to get aspirin, but you just have to be. And it's not a. Have I given people with an inferior wall MI nitroglycerin? Yes. But I won't even consider it unless I've got at least a systolic of like 160 and a 1,000 back up. Because I know it's gonna drop it like 30 to 40 points systolic. Okay? So you just have to be careful. Alright, what else? So you can get a Winky-Bach from increased vagal tone. You can get it from ditch toxicity, which there's not many people running around on digoxin anymore, which is good, because it's got a very narrow therapeutic window. and it can be toxic. Okay? People can also see purple and yellow halos around things. Kind of wild. But sometimes people are on it because they're so screwed up that it's the only drug that works for them. Okay? Other electrolyte imbalances and certain other meds can cause it. Okay? They are usually symptomatic. All right, so Mobitz type 2. It is more serious than Mobitz type 1. This is the area you get to where your atropine is probably not going to work, and it's probably not caused by a vagal tone, and this is where you put your pacer pads on. Okay? They're probably going to be symptomatic. The PR intervals are the same throughout, but you have extra P's, and they're not conducting through to cause a QRS. Okay? So they're going to be bradycardic and most likely symptomatic. And for these, for any kind of rhythm interpretation, it's better to look at a 6-second strip versus your 12 lead in terms of figuring out the underlying rhythm, because the 12 lead doesn't give you 6 seconds. It only gives you like a little snapshot of each lead. So especially for second degree types 1 and 2, it's hard to see unless you have a longer strip to see if you've got that PR interval increasing or staying the same and dropping, even for third degree. So look at the longer strip if you think it's a block. All right, so some of the causes: ischemic heart disease, acute anterior wall MI, which you're going to see in leads V3 and 4. This will all make sense at some point in the near future. You can get infectious heart disease. People can get infections of their valves. They can get infections of their heart muscle. So also, they may have had cardiac surgery, and that can cause them to go into this. Okay? So, emergency care may require TCP. Anybody know what that stands for? Transcutaneous pacing. Yes?
Can you differentiate again between type 1 and type 2, please?
Mm-hmm. Okay. So, all right. Does this one? This one is not the best example. Because it doesn't really get longer.
Yeah, it's just,
That's not a good example.
yeah,
Okay.
it's not.
They're kind of reminds me of third degree.
Yeah, I mean, honestly, this looks a lot more like a second degree type 2.
Yeah.
Because you don't see the lengthening of the PR interval. I'll find better pictures.
Okay.
I'll find better pictures,
Okay then.
because that wasn't it. Alright, so it can turn into a third degree without warning, and that's not good. The QRS is usually pretty wide, okay? And just put the pacer pads on. If you have second degree type 2 or third degree, just put the pacer pads on, even if they're not symptomatic, because they can become symptomatic at any second, right? So put the pacer pads on and just be ready, right? Can you try atropine? Sure. Is it going to work? No. But the protocols say you're supposed to do it. Can you give him fluid? Sure. Does it help the blood pressure? Yes. Okay? But it's not going to make the heart beat like pacing will. Okay? All right. So here we got a third degree AV block. So this is where it gets blocked at the junction, and the atrium's beating, so you got your P waves, your ventricles are beating, but they're not talking to each other. They are divorced, okay? They're mad at each other, they're divorced, they're not talking to each other. But it marches out so that the P to P is the same, because that's a regular thing, but it's not talking to the QRSs. The QRSs are also equally apart, but they're not corresponding to each other. This is also not the best picture because usually the QRSs are wider in third degree. Those are fairly narrow. And they, like I said, with second degree type 2, it can go back and forth between second degree type 2 and third degree. Okay? Does it matter what it is at any 1 second? No, especially if they're symptomatic, because we're just going to treat it, right? We're going to turn on that pacemaker, we're going to set it to 70 and 70, and wait till we get captured. The rate at 70 is fine. You may have to turn it up. You may have to go up to 80, 90, 100 with the milliamps just to get capture. How do we know we have capture? What do we see?
What's that? What's that?
Little arrow things.
Arrow things? No, that's how you know you got, that's synchronized. How do we know on,
Perfect line straight up.
you see the spike, right? But you should see a QRS, it looks like a PVC afterwards. That means you have electrical capture, okay? How do you know you have mechanical capture? Yes, they're pulse, okay? So you gotta have both for this to be working, right? Because it can look lovely on your monitor, but if they're dead, that doesn't help them any, right? So you have to have both. So feel their pulse and watch the screen, and you may have to turn it up a little so that you get both. Okay? Pacing is wonderful. Does it hurt, you think?
Mm-hmm.
Yes. Yes, it does. So you may have to give them some procedural sedation. But if you're pacing them appropriately, they'll have a decent blood pressure so that you can give them some Versed or some ketamine or some fentanyl. Okay? Yes.
So you can safely touch a patient that's being
Yes.
cased, unlike someone who's being defibrillated?
Yes.
Okay.
Because it's milliamps are much less electrical units than joules.
Okay.
Okay. So you're not gonna, can you feel it? Maybe a little, but it's not gonna hurt you.
Gotcha.
Okay. Good question. Anybody else? Questions?
You know Rich Linehan?
Yes.
You explained the type 3 the same exact way you explained it. That's why I was asking. Like I could hear him in my head saying.
And he just got Educator of the Year in Orange County. So.
Yeah.
All right. So what do we have to have for knowing that we have capture?
Pulse.
The pulse and seeing the electrical, the beat after the line on the screen. Okay. All right. So that was perfect timing, Steve.
Okay.
Because you walked in when we were talking about artificial pacemakers.
Cool.
Do you have a presentation, or are you just gonna? Okay. Okay. I don't think this goes into it all that in depth.
Yeah, it's not, we'll talk
Well, it does
briefly
actually.
about, yeah, we'll talk briefly about some of the stuff and then go from there.
Oh,
Um,
we couldn't play that either.
yeah, I dropped all the stuff off the page, fill my water bottle with some ice, we're good to go.
All right.
I'll get what, everything.
Yes.
So, I'm sure all of you have either heard or seen of patients that have implantable pacemakers, right? There are a bunch of them out there on the market, and they do a bunch of different things. This will probably gloss over a lot of the details, and for most of it, for us, that's okay, because until you get into critical care and even high-level critical care transports, you're not going to be worrying a lot about what a pacemaker is doing in a sense when it comes to your patient. The things you have to recognize is what is it doing and is it acting the way it's supposed to. If a patient has a pacemaker, the first thing you want to ask them for is their card. Right? They all should have a pacemaker card that they get when they have the pacemaker planted. Some of them are pacemakers, some of them are defibrillators, some of them are pacer defibs. Okay? The card should tell you exactly what it's programmed to do and what it's exactly designed to do. All right? Perfect example, I actually spoke with him about 20 minutes ago. My father has an implantable pacemaker defibrillator. His is only designed to overdrive pace when he has VTAC. That's it. All right. His bradycardia rate is set to 30. So in reality, if his rate goes all the way down to 30, it's probably gonna be far too late for the pacemaker to kick in and take over. But he had a ventricular arrhythmia, was seen in the hospital, and they found that overdrive pacing worked to correct it, so that's what they put in for him. He doesn't even get defibrillated right away, so it's an overdrive pacing for him. So his card says that stuff. All that stuff is going to be available to you. So that's kind of the thing when you see these pacemakers, or when you see patients with these pacemakers, first thing to ask them is, well, what kind of pacemaker? Is it a pacer defib? Is it a defib, or is it just a pacer? And where's your card? Right? Most men will carry them in their wallet. Most of the women will carry them in their purse or whatever they keep with them at all times. All right, kind of just a habit. The pacemakers consist of a pulse generator, as it says, and then wire electrodes. Where the electrodes go and how they're run depends on what the pacer is designed to do. Some will get run just to the atria, some will get run just to the ventricles, some will get run to the atria and the ventricles. And the design is the pacemaker is not only going to go ahead and trigger and pace the patient, but it's also acting like your cardiac monitor. It's sensing what's going on inside the patient's heart. And that's why my father, when his pacemaker recognized that it's a wide complex tachycardia, it starts overdrive pacing him, meaning if the rate's 120, it goes to 160, and then slowly backs down the rate in hopes that it'll go right back into a sinus once it comes down slow enough. All right. There is programmable hardware. Most of the time, they are under the left clavicle, not the right. You guys all learned throughout your CPR courses that if we had one on the right, you couldn't put your defib pad on that side of the chest. You had to move it below that or to the side of it. Consistently, you see them on the left side of the chest. It's just a shorter run down the left subclavian and then down that direction towards the heart. So that's the side they normally put them on. The biggest thing is, and my father made the joke tonight when I saw him. He's like, I can't lift up my arm like this, and it's actually true. So as the pacemaker for the first 4 to 6 weeks is healing, they cannot lift their arm up. If they do, they risk crushing the wires and disconnecting the pacemaker. All right. So that's he actually was in a sling for 2 weeks where he had to keep his arm down, and then he was not allowed to drive for 6 weeks. So you'll learn as you see these patients more and more, they know, some of them know a lot about their device because they really care. Others know, yep, they put it in, it saved my life. Here's the card. I don't know anything more than that. The other aspect of it, and again, speaking about my father, he has a device where it's plugged into the wall, it's connected to Wi-Fi. If he feels anything, if he feels short of breath, if he feels dizzy, or if he feels anything, he takes his device off the charger, puts it to his defib, it automatically reads his defib for the past 24 hours and sends that to his cardiologist. And the cardiologist will know. All right. It doesn't help us because we won't know, especially if it's after hours. We're not going to be able to call the cardiologist or anything like that. But they can actually read their device remotely now. So there's a lot of advancements in these devices, and I'm sure by the time I'm done speaking, there's going to be even more. So they do generate this universal, unique vertical spike. So you see it here across the line. It's that spike. You'll notice, are there no P waves? No. Okay. There are some devices that are both atrial and ventricular. They're dual chamber pacemakers. They will have 2 spikes, and you will see a P wave and a QRS complex. One after the first spike, one after the other. And we'll go into that hopefully as we move forward. All right. Single chamber, dual chamber, and biventricular. So you'll see which spikes are which. Take a guess. So what is this? So these are both pacer spikes.
That's the,
This is the atrial, all right? This is the ventricular, okay? So the atria contracting, remember, how much of an electrical impulse do we see from the atria when it contracts? Do we see a lot? No. We barely see a P wave. And where is its repolarization hidden? In the QRS, right? We don't see it. We don't see a repolarization like we do in the T wave of the QRS complex, of the ventricle. So this is not only your atrial spike, but it's also it's not only your pacer spike, but it's also your atrial contraction. It's stimulating the heart to actually go down the normal pathway. Which pathway is it going? Is it going down the normal pathway from AV node to bundle of His to Purkinje fibers to the tissue? How do you know that? Okay. How else do I know? It's even more simple than that.
There's pulse.
Well, yeah. But your normal QRS complex has a pulse. what makes this QRS complex, what tells me about this that it's not following a normal pathway? It's wide. Simple, guys. That's a wide QRS, right? It's not following the normal pathway. Normal pathway, that QRS is nice and narrow. Starts to widen when we get bundle branch blocks. Really widens when we get into VTAC and idioventricular rhythms, right? Your pacer is basically, it looks like an idioventricular rhythm, just accelerated with these pacer spikes. So when you look at the monitor on this patient, and you'll, as you ride with experienced paramedics, the first thing, they see a rhythm like this that you can't see pacer spikes, and it's at like 80, the first question you're gonna hear them say is, do you have a pacemaker? Because they're gonna recognize, this looks idioventricular, and it shouldn't be that fast. So the only reason that should theoretically happen is a pacemaker. Why are you smiling?
Because that's this.
And that's what you do. You'll see an idioventricular rhythm, and you're like, do you have a pacer? And when they say no, then you start having the palpitations, because then it's bad. Because then this is something that we need to be concerned about. But if you see a wide complex, and you say, and you don't see pacer spikes, the first thing you're going to ask is, do you have a pacemaker? Because sometimes in lead 2, 3, and AVF, which most of your monitors are definitively set to go to right away, won't catch the pacer spike. You won't see it clearly in those leads, all right? But the second you put a 12 lead on, you'll start to see them. And if you have a Medtronic machine, and the Medtronic machine is set up to identify them, you'll see little arrows at the bottom of the screen. It tells you, hey, the pacer's there. Don't always trust that either. All right? No, can't see them?
No.
Yeah. And there's sometimes you're not gonna be able to. And then if the patient's unconscious and you see this, and it's a diabetic emergency, the first thing I do is rip their shirt down over their left collarbone and I'll look for it. Or I'll push it on their chest. People are like, what are you doing? I'm like, relieving my palpitations. So you just calm down over there, all right? So that's the thing. Single chamber, most of your single chamber pacers are gonna be ventricular. They're gonna be on your older patients. They're not gonna try, a lot of these patients, unless they really think they need a dual chamber, which is also called the AV sequential, they're not gonna put the dual chamber in, right? If they just need ventricular support, they're just gonna put the ventricular support in. You do get subatrial kick with a ventricular pacemaker. Unfortunately, the ventricles are contracted, so it's not really gonna kick through the valve like, you know, a normal atrial contraction would see. So, but that's normally your single chamber. If you have a single chamber pacemaker that's atrial, it can progress all the way through because it's creating that atrial, it's creating that P wave, it's creating that SA node B. And then if the rest of the conduction system of the heart is working and they can track it through, it will go through the rest of the conduction system and you'll actually get a normal QRS after that. So you'll only see an atrial paced patient. Those are incredibly rare, but they are out there. But most of your patients that you're going to see on a pacemaker in the field for us, they're going to be single chamber and they're going to probably be ventricular paced. All right. The dual chamber, the AV sequential, it's exactly what it says. Triggers the atria, triggers the ventricles, and it's using both chambers. All right. Those you tend to see less, like I said, less common than most, but they are out there. And then biventricular, those are the patients that actually need dual stimulation of both chambers of both ventricles in order to get the beat to actually function properly. All right. They normally have a significant amount of cardiovascular disease and congestive heart failure or cardiac failure. So you're going to see those in those patients that are very, very, very significant as you move forward. Fixed rate, in all honesty, I don't think I've ever seen any implanted defibrillator that's fixed rate. And it's honestly because you want the patient to have that variability in their ability to sometimes in their pacer to change the rate. The pacer can sense, you know, certain things, certain conduction abnormalities. The body will still, like if the heart starts increasing the rate, it can actually compensate. You will see pacemakers that will change the rate as the patient is, you know, on their pacer. But most of the time, you're going to see a demand pacer, right? And that's the one where you'll see a patient suddenly look like they throw a couple of PVCs or 4 in a row here, but you look for this. So there's your pacer spike. And that means there was a pause, all right? So from here to here, it measures this R to R interval, okay? And it knows, okay, this is the R to R. And the monitor, the pacer is set to sense, okay, that's an R. That means in, you know, 8 milliseconds I should see another, or less than 5 seconds I should see another R. And that'll give me a heart rate of greater than 60. Okay, cool. All right, if I get, 60 beats a minute, That's what it's programming this R to R to recognize that, all right? And it's going to recognize R to R, and then if it extends too far and it doesn't sense another R wave, it's going to say, okay, I need to kick in, and I'm going to kick in and fire at the 60 rate until the native heart kicks back in again, right? So in between every single one of these beats, it's sensing, all right, is the heart going to do what it's supposed to do? Nope, then okay, then I'm going to do it. Is it going to do what it's supposed to do? Nope, okay, I'm going to do it. Nope, okay, I'm going to do it. And all of a sudden, you'll see this, and then all of a sudden be one of these. And that means the patient's heart kicked back in on its own. P wave stimulated QRS, and we have normal beat. This pacemaker only will fire as the patient needs. So if the rate drops below 60, you'll start seeing pacer spikes. If you look at our transcutaneous pacers that we use, right, they do the same thing, right? If it senses R to R waves, it will not overdrive pace. It won't go higher than their rate. So when we talked about pacers, I think last week we were talking about what are you setting the rate at? Well, if their intrinsic rate is 50 and they're hemodynamically compromised and you wanted to increase their rate above 50, your rate has to be higher than 50. Otherwise, your pacer is never going to fire. It's going to sense this rate and just keep going, say that's okay. Because you got me set at 50, that's 50, I'm not going to do anything. Again, my father, his rate is set at 30. You'd have a heck of a long pause before you'd see his pacer kick in. And it's because his was never designed for rate control. It was only designed for overdrive pacing for his ventricular arrhythmia. These patients will sometimes, all of a sudden, the pacemaker, as the battery starts to die, as if the pacemaker at all is damaged, you'll see loss of sensation, all right, or loss of sensing. It's not sensing the appropriate way. If the patient becomes profoundly bradycardic, there's a good chance you're not seeing, and the QRSs aren't popping up, and the pacer's not popping in. It's because the pacemaker is failing to sense that it needs to be. And that's normally either a battery needs to be changed or the device needs to be completely changed out itself. The battery needs to be changed, the device is going to be switched out. Right? So the pacer is losing the sensing capability. It means it's sensing everything, or it's not sensing everything according to what it's supposed to. It's either not sensing the rate because it's failing, or the leads that are on the heart that are designed to sense the heart rate are not doing their job. And something needs to be adjusted. Your treatment for that is, guess what? Speak up. Speak up. Yeah, you're going to put your transcutaneous pacer on, and you're going to do the same thing, all right? Because there's nothing like, if they're having issues like this, chances are these P waves aren't going to be happy, and natropine's not going to be a fun drug to use. But I think protocol says you're still supposed to do it. All right.
Protocol.
Yeah. Everybody likes to give atropine. It doesn't do a damn thing. When the heart is that sick, it doesn't do anything. Okay, so malfunction occurs. Again, natural pacemaker is what needs to be there. There is there, like we said, failure to capture, failure to pace, or failure to sense. That's when it's your bradycardia. All right. It can also oversense. So if somehow a wire or an electrode that's in the heart gets loose, what happens to our wires when they shake? What do we get? Artifact. Guess what their pacemaker can do? Sense artifact. Okay. That's how some of these patients that have ventricular defib alongside the pacemaker, if the wire becomes loose and it starts causing artifact, the pacemaker starts sensing VTAC, and they'll actually get defibrillated. All right, it can happen. So if they say I got shocked 3 times when I have a defibrillator, okay, it's a problem. We got to figure out what's going on. But that's another part of their differential, because if theirs is going off 3 times, okay, either their heart is sick again and there's ischemia and they're having a lot of ectopy, or there's a problem with the device. So when there's a device involved, the first thing you do is evaluate your patient. Then you try and evaluate your device. For us, how are we evaluating this device? Look it on the monitor, see what it's doing, read the card and go, okay, it looks like it's doing what it's supposed to be doing, or it doesn't look like what it's supposed to be doing. And where do they go? Which hospital?
Cardiac center.
That's the important part, okay? These patients can't go to Ellenville. Honestly, they can't go to Mid-Hudson, all right? They don't have cardiac services in-house 24/7, okay? You even have to look at some of and I'm a big proponent of St. Luke's. is a cardiologist from St. Luke's gonna come in for a pacemaker failure? They may not, okay? Especially for those of you that work on the other side of the river, if you are south of Kingston in the Esopus area, or north in the northern Newburgh, southern Marlboro area, your choice is probably gonna be coming to Poughkeepsie, right? Coming to Vassar, right? Because they have the resources 24/7, 365. That's the important, when you guys transition to your role as paramedics, not only is it about treating the patient, and you know, you'll hear get the patient to the hospital. That's 100% our job, but the hospital isn't just any hospital. You know, unless it's an airway emergency, or, oh, they're gonna code in the next 3 minutes, the closest hospital may not be the best hospital. It's okay to start bypassing hospitals with the appropriate phone calls and the appropriate things to do.
Never mind, you just answered my question.
Yeah. Don't take it upon yourself and start bypassing hospitals.
I was gonna say, would you call like, say like Luke's, like if you're in Newburgh or something, would you call Luke's and be like, hey, do you have the capability to take this, or go to Vassar?
So there was a patient in northern Newburgh that was a cancer patient that was hemodynamically compromised, profound hypotension, and all of her cancer treatment was at Vassar. And I called Med Control at Luke's to bypass that facility, and that doctor told me no. And I did it anyway. So that's where the patient belongs, okay? So again, I'm not the right person to ask. That's also 20 years of experience, so don't do it, do as I say, not as I do, okay? In reality, yes, call and ask, okay? Perfect example, New Windsor 3 weeks ago had a shotgun pellet to the eye on the grounds of the preserve. They called Luke's. Trauma surgeon was in the ER. They said, we don't have ophtho. It's got to go to Westchester. Done. There's no question there. You can have those conversations with the ER physicians, all right? They should know their resources, right? So it is a good thing, especially you guys, early on in your career, make the phone call, because then it's not on your shoulders, it's on theirs. If you call them and they say, yes, come to my facility, and then the patient dies in their facility because they weren't prepared, you can only do as you're told, all right? I had the same disagreement with when that massive the bus full of kids rolled over on 84. Do you know what the closest level 2 trauma center was? Go ahead. Orange, right?
Or
And Garnett. And you know what their response was? We can take every patient. No. That is never the appropriate response. The appropriate response is, we can safely handle 3 red, 10 yellow, 10 green. So that's 23 patients. That 24th patient that arrives now allows them to say, we were overwhelmed. We couldn't handle it. And guess what? Okay, you were overwhelmed. But the second you say, yeah, we can handle everything, and that 24th patient dies because you couldn't handle everything, now it's on you. So same thing for you guys. When you get out there, take the burden off your shoulders. Call the hospital, call your med control physician, and say, listen, this is what I got, this is what I'm thinking, this is what I think they need. I want to come to you, but I don't know if that's appropriate. There are some hospitals that will tell you no matter where you want to go, you can go elsewhere. You call certain physicians at St. Luke's, and you say, I want to go, yes. But that's, oh, okay. They won't care. If you want to go elsewhere, they'll send you elsewhere. There's also physicians that say, you can't bring that here. Watch me. If I don't feel comfortable bringing it further than your hospital, it's coming to you, because you have more resources than I do. Right? If this patient isn't responding to pacing, if this patient is hemodynamically severely compromised, and you can't manage them, not only do they have a better pacemaker, they have the ability to put in a transvenous pacemaker, they also have more drugs in their repertoire than you do to help treat this patient. So, listen, I'm bringing this patient, they're really sick. Why? We can't handle that. And the classic case is peds. All right? Well, we're not a peds center. I don't care. This kid is really sick, they need to go to the closest hospital. You have more resources to manage this patient than I do. And that's the right answer. Runaway pacemaker, it's going crazy. It normally has an issue with it sensing, it's not sensing correctly, or it's saying, I'm not recognizing this patient's heart is beating, so I'm going to keep firing. All right. There are times where it will actually overfire and you'll get significant tachycardia. Really, the only way to fix that is with the wonderful magnet at the hospital. They can reset the pacemaker with a magnet. All right. Medtronic, you'll see it's a little donut, a little circle, goes right over the pacemaker, and it's designed so when the patient goes to surgery or anything like that, they can shut down the pacemaker. If they need to do anything on the surgery table that may affect that pacemaker or anything like that. So they can place that, it shuts down the pacemaker, and then normally they'll go ahead and reprogram it and reboot it. If you get a chance when you go to Vassar, go, if you can, I'm sure you're gonna do cardiology time, right? If you get a chance to see a patient with a pacemaker, see if you can see if the Medtronic rep, or whoever the brand is at this point, will probably be there at some point during your time, and because they're placing these things every day. You can actually see, they can actually download everything in the pacemaker. And there's so much more that goes way beyond anything that we'll cover in paramedic class. It senses, how it senses, where it's sensing, what the sensitivity is based on the setting, how sensitive it is certain times, other times what it also is sensing. There's so much in the background that it would take, it's actually a 8-hour online course through Medtronic that you can take. And it goes way in depth, right? But again, that's much more high level, more critical care stuff that you guys need to know. For you guys, the biggest thing to remember is my patient perfusing? And if they're not, why, right? With your pacemaker patients, you have to figure out, is it a device issue or is it a patient issue? Right? For device issues, also remember that it's not just about whether or not the device is working, but also whether or not the heart is responding. Profound heart failure patients that have pacemakers, if the pacemaker is working like it's supposed to, and the patient's complaining of chest pain, or the patient's short of breath and hypotensive, does it mean that the pacemaker is failing? You see a normal, that's what you see. Marching across. Pulse ox isn't reading, blood pressure 70 systolic, and the patient's short of breath. You barely have a carotid pulse. Is the pacemaker functioning?
Mm.
It's a trick question. It probably is. All right. These patients that have pacemakers also probably have some component of heart failure. All right. If the heart failure progresses, just because the pacer's causing that left ventricle to beat doesn't mean it's beating with strength. Nicole, what was the EF on that patient yesterday?
Yeah.
The ejection fraction of the left ventricle.
Oh, yeah, I can't remember.
Yeah, less than 5%.
Ooh.
Oh, yeah, okay, now.
Yeah, peri-arrest in the ER at St. Luke's. Dr. O'Hari put the ultrasound on the chest, and you literally saw the left ventricle doing this.
Yeah.
And at that left, this can beat as much as it wants. If that left ventricle's not squeezing, it doesn't matter. All right, you're not gonna get a strong carotid pulse. And it was amazing to see. Like the fact that, like, we're all saying, oh, that looks like a great sinus rhythm on the monitor. At that point, a great junctional rhythm, or eventually a great ventricular rhythm. But there was no pulse with it. And we couldn't figure out why. And then Ahari put the ultrasound in the chest, and you had no pulse because the ventricle was responding, but it literally, the walls were never even coming close to touching.
They tried to do it to CAT scan like 3 times.
Yeah, she coded 3 times. Already CAT scan.
So, does anybody know what a normal ejection fraction is?
45%?
50 to 75.
Yep. Yep, good. Above 50.
Above 50. Hmm?
50 to 70.
50 to 75.
Can you have heart failure with a preserved ejection fraction?
Yes.
Why? How?
Oh,
Magic.
Take it back.
Well, where is heart failure? Besides, don't say the heart, then I'll throw you out. But where is the heart failure? That's what matters. What's the most common type of heart failure? Where in the heart? Think which chamber? Left ventricle. Left ventricular failure is the most common failure. Why? Because it's the workhorse. It pumps the body, it pumps the blood everywhere. What is the second most common? There you go. See? Woo, process elimination. We're getting good at this. All right. What's the most common cause of right failure? Left failure. It's left failure. All right. What's the most common cause of left failure?
Right failure.
Prolonged systemic hypertension, untreated hypertension. Teaching you about my future.
Or you're going to be the cause of that in us.
No, I have hypertension. We're going to have a nice discussion with my doctor on Friday. It's going to be good times. So, but all this stuff is connected, and that's part of like, this patient here, I'm gonna guarantee has heart failure. If their conduction system has failed, they have some sort of ventricular failure, left or right. You can have isolated right ventricular failure, and the most common cause of that is some sort of pulmonary issue. Think about it. If something is causing that side of the heart to work harder, that's what's gonna cause it to fail. So the tank being super tight or full of fluid, hypertension, causes the left side to fail. The lungs being full of fluid, significant either respiratory disease or a pulmonary embolism will cause the right side of the heart to fail. So you have right failure that stems from the pulmonary system, left failure that stems from the systemic system. That's how you kind of have to look at it. So your patient in profound pulmonary edema, sudden onset pulmonary edema, where's the failure?
Right.
Left, because the left backs up into the lungs. All right. The patient who has significant edema everywhere, well, it's probably combined, but the right side isn't clearing that ventricle fast enough. It's probably everywhere at that point. But if your left side is failing, you get sudden onset pulmonary edema. Patient that presents sudden onset pulmonary edema, shortness of breath, and profound rales, and the 12 lead looks, well, it looks kind of funny. It's probably a STEMI. Sudden onset of acute pulmonary edema with no history, it's probably a STEMI that you're not seeing.
Luckily, we don't see that as much anymore.
We used to.
It used to be a couple times a week.
Yeah.
But now the meds are better, so it prevents them from, filling up with fluid all the time in their lungs. Thank goodness. And we didn't have CPAP, so we used to have to tube these
Oh,
people
yeah.
all the time.
Everybody, and it was even better when you like, oh, well, I'm just gonna go ahead and give them a treatment because they sound a little diminished in the basis. They're fine.
That worked out well.
And yeah, I didn't have an IV either, so yeah, they got intubated when we got to the hospital. It's fine.
All right. Any questions about that?
There's like I said, 8 hours worth of pacemaker stuff, but when it comes to you guys, recognize that knowing what kind of pacer they have and what it should be doing, looking for the pacer spikes, looking for the ventricular spikes if it's just a single chamber, looking for that, that wide QRS that would accompany a pacer spike, and then if they have a dual chamber, looking for both spikes, and then recognizing, okay, is it a patient problem or is it a machine problem? And as you get further and further on in paramedicine, you get into a lot of situations where you got to figure out, okay, is it the patient or is it the machine? And it doesn't have to just do with the heart. Ventilators, pumps, medications, all that stuff. LVADs are a lot of fun too. But that's when I really nerd out. So
Make sure you bring their batteries.
that's my favorite. That's the one heart failure patient you get tons of fluid.
I just watched a TikTok of this guy explaining his LVAD. He's a